Hello, everybody. Good afternoon to those of you in our time zone here at Sick Kids, and good day or good evening to everyone else in other parts of the world. For those of you who are just logging in with us today, welcome to the Sick Kids annual Pain Center Conference. So we're talking about the title of Advancing Pediatric Pain Equity, Addressing Challenges and Opportunities in Low and Middle Income Countries in this conference today. For those of you who have been with us throughout the day, I hope you've been enjoying the session so far. My name is Jacqueline Hanley. I'll be your moderator for this session, which is called Strengthening Neonatal Pain Assessment and Management in Small Island Developing States, Lessons from Barbados. We're really excited to hear from our next speakers who will be sharing their experience using quality improvement to implement pain assessment and management strategies in the NICU. I am pleased to introduce three speakers to you today. So we have Abeo Benjamin-Walrond, Dr. Gillian Birchwood, and Christine St. Denis. Abeo is a highly skilled registered nurse with over 14 years of experience in neonatal intensive care. She has a postgraduate diploma in pediatric nursing and is dedicated to optimizing neonatal health through advanced practice and interprofessional collaboration, while also championing mentorship and evidence-based quality improvement. Welcome, Abeo. Dr. Gillian Birchwood is a pediatrician and neonatologist and currently serves as a consultant neonatologist and head of the Department of Pediatrics at the Queen Elizabeth Hospital in Barbados. Dr. Birchwood also serves as faculty at the University of the West Indies and is involved with supervising research projects and training medical students and pediatric residents. Dr. Birchwood has also worked to promote newborn care across the Caribbean region in her role with the Pan American Health Organization. Welcome, Dr. Gillian Birchwood. And Christine St. Denis is not only an interprofessional education specialist at Sick Kids Center for Global Child Health, but she's also a dear friend of mine and someone I've known in my nursing career for a very long time now. I think we met in the beginning of nursing school, so I'm very pleased to have her join us today. Christine leverages her 17 years of nursing experience to drive capacity building initiatives with international partners in resource-constrained countries. Her work includes co-developing and delivering a postgraduate diploma in pediatric nursing at the University of West Indies and strengthening quality improvement across the health sector in Barbados. So we're very excited to have the three of you join us today. And with that, I will turn it over to you.
Thanks, Jacqueline. I'm just going to share my slides. Okay, so that was a really great introduction, so I don't feel like I have to say much more, but just to share that, a lot of this work that we will be talking about is going to be focusing on neonatal pain assessment and management, and really brought through the lens of an interprofessional quality improvement project. So my role really was around mentorship and support of this quality improvement group. Abeo was really, one of the frontline nurse leads for this QI group, and all of it was really spearheaded from Dr. Gillian Birchwood, who's the co-lead of the NICU group. So how this presentation will go, just 1 second. So we're going to start the talk. Dr. Birchwood will provide some context about the country and the hospital setting. It'll be followed by some discussion on key barriers that were encountered in pain assessment and management practices within their NICU. And then Abeo and I will walk you through some of the strategies and approaches which were implemented to address these challenges. Finally, we'll loop back to Gillian, who's going to return to share some insights on how the QI group is looking beyond Barbados to explore ways to foster regional engagement across the Eastern Caribbean to champion evidence-informed pain practices. So over to you, Dr. Birchwood.
Thank you very much, Christine. Christine is extremely highly regarded here in Barbados, where she has really been a foundation for QI and introducing that to us. So we're very grateful to Christine for all of her support. So I am greeting you from warm and very sunny Barbados. And I know when most of you think about Barbados, you think about warm blue sea, you think about lovely golden sunshine, you think about nice sand. I know you want to come here right now. All of that is true. But I think that beyond being a tourist destination, I really wanted you to get some context about Barbados that perhaps you might not know. So Barbados is a very small country, not just physically, but we also have a population of just about 270,000. And that is about the population of just downtown Toronto. So it's really quite a small country in terms of size and population. From November 2021, which was about 4 years ago, we became a republic. So we no longer have a monarch as our head of state. And although Barbados is on paper a high income country, which puts it in the same category as Canada, the United Kingdom, and various other parts of the world, we actually face a unique set of challenges because we are also a small island developing state. And what that means is that we have specific vulnerabilities. And that is, for example, we're very subject to external shocks that are beyond our control. For example, look at the hurricane that just affected Jamaica. That is something that is a tremendous challenge that's beyond their control. And we're also subject to climate change vulnerabilities. As a small country as well, a small island developing nation, we have shortages in healthcare in terms of human resources, material resources. We have limited opportunities for training and education. And we have a very high dependence on imports because we can't produce everything that we need. And so because we are tiny and far away and geographically isolated, we also have supply chain issues. When we are trying to get supplies in, sometimes we're told, well, we can't send it there, it's just too small a quantity. And so we are very acutely vulnerable to many things as a small island developing state. And layered onto that, we have a legacy of colonialism and colonization. And our Prime Minister stated, that's Mia Mottley, she stated, our journey to independence started with a chronic deficit, a deficit of resources, fairness, and opportunity. And that is still true today. And so building on that context, it's important to understand that in building and trying to build a resilient and equitable system for our country can be challenging. So our neonatal intensive care unit, we're very proud of our unit. We have just one main public hospital in the whole of Barbados, and there's just one neonatal intensive care unit in the entire country. And this serves not just the country, but also the region, which is a catchment area of about 1 million people. So if we have moms and, who are having high-risk pregnancies or babies, they will be transferred to our referral center. So we are one of the larger NICUs in the region, and we are a 25-bed level 3 NICU. So we have a team of about 17 nurses, 3 consultants, 2 head nurses. We have 7 auxiliary staff. So we do have a multidisciplinary approach to neonatal care. Our unit has 17 incubators, even though we're a 25-bed unit, don't ask. We have 8 ventilators, and we have 2 radiant warmers supporting care of babies who are born from 600 grams and up and 24 or 25 weeks and up. And we take care of babies who have respiratory distress, prematurity, sepsis, and and other causes of respiratory distress syndrome, for example, like in premature babies. So let's drill down a little bit and look into why are we here today. We're here to share our journey in advancing neonatal care practices from our unique perspective in the Eastern Caribbean. And we're focusing on a quality improvement initiative we had to promote neonatal pain management practices. Now, with our unique circumstance, there can be unique challenges. So something that seems like a very simple thing can actually really be met with a lot of barriers. So even though there is very strong global evidence to support safe and effective pain management strategies, procedural pain relief for newborns is really quite insufficient across the Eastern Caribbean, and in fact, through most of the Caribbean. So this gap is not only because of a lack of knowledge that does play a part, but it's also due to deficits in our systems, in our tools, and in our consistent practices. So to better understand the landscape in which we were operating in, we did an environmental scan, a little survey across all the dedicated NICUs in the region, from Jamaica and Bahamas in the west, through St. Vincent and Dominica, which are in the Eastern Caribbean, and down to Trinidad in the south and other areas. And the idea was to actually benchmark existing practices in neonatal pain assessment and management. And what we found was striking but not surprising. So across the region, there's very limited use of formal tools, of standards, and of guidelines for neonatal pain management. And this situation mirrored what we ourselves knew to be the case in Barbados and revealed, although there was a deficit, a significant opportunity for us to improve this system. So by identifying the gaps, we were able to begin developing strategies to support not just our NICU, because we can never think in our region. We can't just think at a national level. We have to think at a regional level, and to support NICUs in implementing routine pain assessment and management, and to demonstrate that this was something that could be shared across our islands. Okay, this is one of my favorite slides. So before I hand it back over to Abeo and Christine to take us through the different strategies and solutions that we implemented, I want to look a little bit more deeply at the barriers that we had that shaped the starting point of our neonatal pain management journey here in Barbados. So we did a root cause analysis. We used various diagnostic tools. You can see the Pareto chart. We did a gap analysis. We used a fishbone analysis. And we identified 5 key themes that really resonated throughout that contributed to the limited use of neonatal pain assessment and management that we found on our own NICU. So the first thing is we found that there are systemic and structural barriers. So there are lack of standardized protocols, and this is not just in our particular area, this is often institution-wide. There's limited policy infrastructure, both on our unit and at the hospital level. There are no guidelines or directives when it came to neonatal pain management or assessment at all. And hospital-wide policies also affected our ability to do this. So for example, visiting hours are restricted and it's a hospital policy. So that means that we have limited opportunities to use non-pharmacological strategies for pain management on our NICU, for example, skin-to-skin care or kangaroo care. There's also no capacity for caregivers to room in overnight, so they can't participate in pain management. They can't advocate on behalf of the babies because they're not there full time. At QEH also, the idea of quality improvement is very much in the nascent stages. It's now emerging. So the idea of reflecting on current practice, identifying gaps, and choosing to improve is really a new thing in our part of the world. The second factor that we identified are sociocultural and other contextual factors. So there are certain ingrained cultural beliefs which influence practice. Unbelievably, some people held the idea that neonates don't experience pain in the same way that adults do. Again, highlighting a knowledge gap, but also an opportunity for improvement. Parental involvement tends to be limited. It's not cultural for our parents to really speak up, and they're not aware of the role that they can play in supporting non-pharmacological pain relief strategies. They don't always feel empowered to speak up on behalf of their infants. Third, and we mentioned this briefly before, was inconsistent supply chains. So if we wanted to be able to have the products and the consumables, for example, like sucrose, which can be used in pain management, getting and maintaining such supply is a challenge in our region. We have such a heavy dependence on imports, and we often get logistical constraints that disrupts our ability to access basic pharmacological interventions. Another challenge is the technology gap. Unbelievably, our hospital is paper-based still, which means that if you want to have digital default systems, which means that you have to, that a prompt is created that says you have got to complete this assessment, you've got to integrate this into routine care. There's no digital prompt, which means people literally have to remember, which is not always feasible. And it also means that when we're going back to look at data, that it is a manual process, which can be quite time consuming, and that can hinder the baseline assessments and ongoing monitoring. And then finally, that we have, because again, we are a small island developing state, a shortage of specialized staff. So when you have a small healthcare workforce, you can have limited access to continuing education, and it can be challenging to implement and sustain specialized protocols. And staff don't always have the opportunities to stay current with emerging best practices in neonatal care. So these barriers not only helped us to understand where the gaps were, they helped us to identify the opportunities for system-level improvement. And so by identifying these challenges, we were able to design targeted strategies that would work in our NICU to implement routine pain assessment and management. And so now I'm going to hand it over to Christine to show more background on how we continued and implemented this work.
Thank you, Dr. Birchwood. So again, a large part of this work was really through a quality improvement like methodology, which was specifically the model for improvement. And really this was meant to make sure that things were, not only realistic and practical, but also sustainable. Um, the approach was anchored in 6 core strategies around quality improvement, and these are really designed so that things could be flexible and scalable, so that they could be adapted in other settings. So, the 6 strategies that were adopted were to adapt evidence based tools and ensure that they're locally contextualized. You wanted to look at building capacity through targeted and ongoing training through the empowerment of local champions. We also wanted to develop high impact protocols that were cost effective and establish mechanisms for monitoring feedback. And then lastly, again, not just looking at things in isolation or at like just a unit level or a micro level, but looking at things at a systems level so that they would be sustainable. I'm going to hand it over to Abeo, who's going to share how each of these strategies came to life in practice.
Thank you, Christine. So, to successfully implement the change within our unit, it was essential that every staff member felt genuinely engaged and that our strategies reflected the unique needs of our community. Rather than relying on generic off-the-shelf solutions, we carefully reviewed the evidence to ensure that every tool and resource was conceptualized to our patient population and integrated seamlessly into our unit's workflow. A key example of this was adapting our unit's flow sheet to include a dedicated space for documenting pain scores, making pain assessment a routine part of care. We also prioritize the creation of educational resources, actively seeking feedback from families, which was a first for our hospital. By involving families in the design process, we ensured that our messages were specific to Barbados and truly resonated with our community. This collaborative approach has strengthened information sharing and sustained education around neonatal pain assessment and management. You can see our pain pamphlet featured on the left of the screen. Finally, we recognize the importance of evaluating each tool and resource for its fit within our environment. Where possible, we adopted proven resources such as the NITS Pain Score tool to maximize impact while being mindful of the limited human resources. This thoughtful, context-driven approach has allowed us to make meaningful and sustainable improvements in neonatal care. As Dr. Birchwood noted, we had identified there were several opportunities for education and capacity building when it comes to neonatal pain management. We started with initial training to ensure that the current staff felt competent and confident in these pain management best practices, including education on pain assessment, management, and the use of new tools and resources, using an interprofessional approach at the education sessions so that all of the staff had access to the same knowledge and could appreciate what the other professions understood. Typically, learning sessions were profession specific, so this was a new approach for us. As time went on, we appreciated that the training needed to be built into routine staff onboarding to ensure that all future staff would have access to this education and so that their practices would be reinforced and more sustainable. Another strategy we adopted to implement this new practice was to leverage some of our NICU nurses as local champions to help this change. This local ownership has increased staff engagement and involvement and ultimately sustainability. Again, we are a small, limited number of staff on our unit. And so when our QA group moved to another project, we didn't want to lose momentum and motivation on this pain project. So empowering other staff members as champions has helped with our ongoing mentorship and education and continued awareness of the importance of this practice. When addressing the challenges of limited pain assessment and management practices, our priority was to implement solutions that would be more sustainable over time. We recognize that protocols or guidelines relying on cost, resources, or medication would not be feasible in our settings, as Dr. Birchwood would have mentioned. So, for example, when introducing a new pain assessment tool, we consider not only the effectiveness, but also its accessibility and durability. To ensure these tools remain available and in good condition, we laminated the pain tools and attached them to chains on each incubator. This simple strategy helped us to minimize loss and wear, supporting consistent use at the bedside. In terms of pain management, we were mindful of ongoing resources availability. High sugar solutions has been a proven strategy to management of procedural pain in neonates and infants. However, purchasing individual sucrose products was not a viable option due to cost restraints. Instead, we collaborated with our pharmacy team, who now prepares and dispenses sucrose solutions in syringes daily. This partnership has made pain management more accessible and sustainable for our neonatal patients and ultimately more equitable by ensuring that there are sufficient supplies for our units so that the staff would not have to pick and choose. Finally, we emphasize the importance of non-pharmacological interventions, such as kangaroo care and breastfeeding, which was previously underutilized. By raising awareness and encouraging these practices, we have broadened our approach to pain management while making the most of available resources. Continuous feedback is at the heart of our commitment to ongoing improvement. By leveraging simple run charts to visibly display key metrics, we make performance data accessible to everyone on our team. These charts, combined with straightforward staff audit systems, enable us to monitor progress and identify areas for growth in real time. This transparent approach not only facilitates immediate feedback and meaningful frontline discussion, but also reinforces our accountability to caregivers and families. You can see that after implementation of our full strategies, we surpassed our target of 50% for performing pain assessment on our patients. We had a little dip in May due to several new staff in our NICU, but after that, we got back to 100%. Lastly, departmental policy and protocols serves as a powerful catalyst for advancing equity in care. Equity is not simply an aspirational value, but it's a practice that must be woven into every layer of our systems. By establishing clear policies and protocols, we created a standardized approach to care, ensuring that foundational principles are upheld consistently, regardless of who is delivering care. Importantly, standardization through policy does not mean inflexibility. Instead, it provides a shared framework that guides decision-making while allowing for tailored approaches that meet the unique needs of each patient and family. Policy acts as a safeguard, embedding process into the institution so that the improvements are sustained over time and not relevant on individual champions alone. For example, our pain assessment and management policy in the NICU at QEH is designed to support family-centered care. This ensures that every patient receives care that reflects their individual context, background, health needs, truly putting equity into practice. You can see a screenshot on the screen that shows our policies and protocols for this project. As we look ahead, one of our top priorities is ensuring the sustainability of our neonatal pain initiative. We are not aiming for a temporary improvement. We are working towards a lasting shift in how neonatal pain assessment is assessed and managed. There are many ways to support sustainability, but I want to highlight two key strategies we are focusing on right now. The first one is continued stakeholder engagement. We know that the people closest to the work is the NICU staff, and they are essential to sustaining change. That's why we are committed to gathering regular feedback on tools and resources we introduce. Their insight help us to refine the system and keep it relevant. We are also exploring ways to share progress more broadly, such as through hospital-wide newsletters to keep the momentum going and build wider awareness. And the second strategy is celebrating success. Recognizing achievements, big or small, is a powerful way to maintain energy and commitment. Recently, our NSU team received the Respect Award, which honors outstanding contributions to quality and service excellence. Celebrations like this reinforce a culture of improvement and reminds teams that their efforts are seen and valued. Ultimately, sustainability is what transforms a project into a movement. Through these strategies, we're embedding neonatal pain management into everyday practice, ensuring that the benefits of this work continue well into the future.
Thanks, Abeo. So those are some of the remarkable strategies that have been implemented to do some of this work. I wanted to take a moment just to talk about, some of the reflections that this group has thought about going through this process together. What helped, and what were some of the lessons that were learned along the way? And the first really is something that Dr. Birchwood kind of highlighted back in some of the identified barriers around data collection. I think this is something that the group really had a big acknowledgement to, that when it comes to data, data is good. We know it's meaningful and that it can be used to drive decision making. But really, data collection to make it effective, especially when human resources are limited and it's manual, a good strategy is to keep it simple, purposeful, and actionable. So when data systems, if they're limited, especially in resource constrained areas, um, sometimes even when they do exist, feedback loops can be rare, making improvements feel like it's guesswork. Um, Other times, people tend to lean too hard into over collecting data. And again, if this requires a human resource to actually manually collect this data, it can actually be overwhelming and really risk pulling the person from patient care. It can lead to fatigue and even possibly errors. So the balance really here is to find that key, balance, to start with a few essential indicators and collect those well so that they can be collected consistently and accurately, and to allow people the space to really see why it needs to be collected, so that there's a direct link on how it truly informs care and decision making. From there, you can build, up that foundation gradually, and trying to always look for ways to design the data processes with ease, um, of use in mind, and to integrate them into, metrics or mechanisms that already exist that can actually make things much easier. And that data really never is an end in itself. It should always drive learning and improvement, and not just to fill like another spreadsheet. The next reflection really is around capacity building. And I think that Abio really touched on this about champions already and leveraging them. One thing that stood out when we kind of looked back at this work, though, was that we know that, sometimes the most influential champions aren't always the loudest voices. They're kind of these silent leaders who quietly model best practices and inspire peers. So if you can identify these individuals early and provide mentorship and create opportunities for them to lead in ways that feel practical and culturally relevant, it really can be the tipping point for change. And if possible, thinking about how we can advocate for protected time and resources so that these champions can focus on improvement work while continuing to provide excellent patient care and not having to pick and choose. And then lastly, the last reflection was really about thinking about stakeholders, and thinking about those beyond the usual table, so including caregivers and parents. So we know that having caregivers, parents, and patients, that they're the ones who experience these changes firsthand, and their perspectives can really help ensure that QI initiatives are patient-centered, and really meaningful and impactful. So bringing their voices to the table helps strengthen trust, it improves adherence to change, and it embeds QI in both institutional culture, but also family engagement. So I'm going to hand back over to Dr. Birchwood, who's going to share a few quick insights beyond Barbados and then wrap up.
Thank you, Christine. So we have reached this point of success in our neonatal pain initiative. We're celebrating, but we have a very important question. How can we actually expand this impact across the region? As I mentioned earlier, we are small island developing states. We can't just think at a national level. We always have to think, can this be scalable outside? So quality improvement is most effective when it's both scalable and it's adaptable to the local context. So our aim is to ensure that the insights and the strategies that we developed in Barbados can be translated into meaningful change throughout our region in the Eastern Caribbean. So to support this, we are developing a regional toolkit. It is meant to be a practical, user-friendly resource that's designed to help NICUs both assess and strengthen their neonatal pain practices. The toolkit is more than a set of documents. It's meant to be a roadmap for change. And it would include things like goal-setting frameworks, problem analysis tools, metrics and evaluation guides, and real-world examples, because we can showcase not only our successes from Barbados, but also challenges that might be peculiar to our context and how we were able to overcome them. But spreading change isn't just about the tools, it's about the people. So when you have sustained change, that requires awareness, and not just on an NICU in some institution, but in the institution itself and in the healthcare system. And while the NICUs can only train a limited number of staff, we need more champions to carry this work forward. And I'm very proud to say that this past August, Abeo, who presented just now, had the opportunity to present our experience at the Council of International Neonatal Nurses, or COIN conference in Zambia. And that was a first for our team and a first for the nurses at the QH. We were very proud about it. It was a really powerful moment that we got to contribute to the global conversation on neonatal pain management. And one of the exciting ideas that came out of that network was the creation of a Caribbean neonatal nurse network. And that's meant to be a platform to cascade training into different islands within our region. And so this model could help to build capacity in resource limited or resource constrained settings that have similar context to ours, when neonatal care is not always the top priority. It may compete with many other priorities in that country. And ultimately, that initiative is about empowering the teams to deliver evidence-based, patient-centered care. And by fostering that regional collaboration, we're building together a culture of excellence with the ultimate aim that we ensure that every baby, no matter where they're born, has the best possible start in life. So when we talk about pain relief, we are not just addressing a bedside issue. We're advocating for evidence-based care. We know that every infant deserves the appropriate pain management, no matter where they're born. And what we've seen through our work here in Barbados is that the interprofessional approach to quality improvement can really thrive, even in a small island developing state. And projects like ours can succeed when they're rooted in collaboration with a strong understanding of our context and a commitment to equity. So our call to action is very clear: to commit to ensuring that every baby receives the care they deserve. And that means that we need to tailor our message and our interventions to the unique context of each community. And when we speak in ways that resonate locally, we can build trust, we can drive engagement, and importantly, we can make change sustainable. So this is more than just about protocols. It's about advocacy, it's about empowerment, and it's about empathy in neonatal care. So I want to thank you so much for the opportunity to speak at this conference. And you see the contacts there. And these are the other lovely members of our neonatal QI team. And it's one meeting we actually enjoy, our weekly neonatal QI meeting. Thank you so much for your kind attention.
Thank you so much to all the presenters. That was fantastic. I always find it really meaningful to hear these unique perspectives and these stories. So thank you for sharing your journey. And I think, being able to hear about, a QI process applied in a specific environment and just those lessons learned and the applicability even beyond your own center, I think is really, really fantastic. If you have any questions, feel free to raise your hand or put them in the chat. again, thank you all for your comments today. If there's no questions in the chat, I think I'll just I have a lot of my own actually, but I'll try to keep maybe to a brief one. You mentioned earlier in the chat that you often find that families don't feel empowered to speak up for their infants. So I think it was really fantastic to hear that you actually included families in the process to ensure that the what you were doing, the work you did actually was sort of applicable in this cultural context and worked for them. Could you maybe just give a bit of an answer about how you felt the patients or the families received that involvement and how that worked?
I think that it was really eye-opening for them to be approached by a medical team and to be asked to participate in something that would affect the care of not only their child, but other children. They really welcomed the opportunity. They really spoke up and contributed, and they gave us perspective that was unique and that we as the medical caregivers would not necessarily have. And it was a perspective that was really helpful, and so engaging them was very rewarding, both for us, but also clearly for them as well. They felt really empowered and heard, which is really important.
That's fantastic. Thanks so much for sharing that. I think in the interest of time, we'll close there. Again, thank you so much for sharing your journey with us and that story. It was fantastic to have you here with us today. Thanks again, everybody.
Thank you.
Thank you.